Our next speaker is Michelle Morrison. For those of you who do not know Michelle, she is our liver transplant social worker par excellence. You see mostly Michelle in the outpatient environment. She works up all of our new referrals coming in for transplant evaluation. She spends a lot of time in the clinic and in working with patients, clearly primarily on outpatient, and she provides some coverage for our other colleagues when they're out of town, vacation, or other. Now, Michelle, for those of you who would pay a little bit of attention on the credentials here, she's a licensed clinical social worker. She's also a certified clinical transplant social worker, so she's double board certified. And that is really a plus for our transplant social worker staff, and it's extremely important to further mention and or elaborate on the type of expertise you have in the transplant program, which is really a big deal for our own in any of our specialties. So most of our staff are either double board certified or double credentialed, including our nurses, social workers, dietitians, and other. So with that said, the second member of our team here who was supposed to be here with Michelle had a minor accident over the weekend, and she's having surgery right now. We wish her the best of luck, or we're keeping her in our prayers. So without any further ado, and I know Michelle has been anxious for me to leave the floor here and let her start with her presentation. Michelle Morrison.
Good morning. Today we're going to be talking about psychosocial challenges in liver transplant. And most of the focus will be on liver because that's where most of my experience is, but I think most of the challenges, apply to, most of the organs that, some of the other social workers work with. So why do social workers need to be involved with transplant? Why do we, look for any psychosocial issues? The main reason is because we have to. The Department of Health and Human Services requires that a social work evaluation be done before a patient can be added to the center's wait list. So that's one reason. But another reason is because there's so many more recipients than what there are donors. Also because, out of all the people who are waiting on our transplant list, to date this year we've done about 25 transplants. So we have so many more people waiting for transplant. So we do our best to evaluate patients who are going to have the best possible outcomes. So as of September 29th, 2012, there were approximately 115,000 people waiting for transplants in the United States. Of those 115,000, about 25 of them were listed in our region here, which consists of Arizona, California, Nevada, New Mexico, and Utah. Of those, over 4,000 were waiting more than 5 years for transplant. And as of that date, we had about 12,000 listed in our local area and 761 listed at UCSD. Out of those, 93 were for liver transplants. So with so many people waiting for transplants, why do so many people choose not to donate? And there are many reasons for that. Some people will cite religious reasons. A big one is different beliefs about the definition of death. Concern that donation will, somehow impact their grieving family, that will interfere, with that process. Feeling that, that maybe they would be violated after death, just that squeamish feeling, of, their organs going to, to strangers, people that they don't know. Oftentimes people will believe that, maybe they're not healthy enough for donation, so instead of, choosing to be a donor and then letting it be determined at the time, they just choose not to donate, believing that they're just not healthy enough. Oftentimes people might think that they're too old, so that they just choose not to donate because they think that they're too old and nobody would be able to benefit from their organs. Sometimes people won't donate just because they think oftentimes people have, needed a transplant because of past behaviors. And sometimes, that is true. Sometimes we do obviously see with our liver patients that, they have liver disease because of alcohol or because of some other past behaviors. And that's where the social worker comes in and tries to really assess that to determine that, that behavior's in the past, and to do our best to predict as much as we can the future that they would not, go back to alcohol or drugs or other things. Some people believe that, the system's kind of corrupt, and sometimes, organs can be purchased. And then others believe that if they were donors, that possibly they wouldn't be able to have an open casket, which, somehow would, interfere with their funeral services. So what are some of the solutions for organ shortages? One could be preventative medicine. Sometimes people might need transplant because of diseases that might be able to be prevented, like diabetes, obesity, high blood pressure. Another way might be to maybe have better education with the public, to kind of sort through what the myths are of organ donation, what the facts are. Some countries have gone to presumed consent, where everybody's presumed to be an organ donor unless you opt out, unlike in the U.S., where we have the opt-in system, where you have to choose to be a donor. Some countries pay for donors, and obviously that's not here in the U.S. So we'll talk a little bit today about what the process might be like when somebody's actually referred, and this is mainly on an outpatient basis, what it's like when the patient is originally referred. So we will get referrals from many different areas. Oftentimes we get referrals from our own hepatology department when their disease has progressed and the hepatologists feel that they're ready to be evaluated for transplant. We get a lot of referrals from outside doctors who are taking care of patients with liver disease, and again their disease has decompensated, so they feel like they're ready for evaluation. So once we get that referral, it's reviewed by our nurse practitioners, and their name is added to a list. And the transplant team has a weekly meeting that we call PAM. It stands for Patient Advocacy Meeting. And during that meeting, the social workers, the nurse practitioners, hepatologists, our financial coordinator, and our transplant assistants will discuss all of our new potential referrals. So, kind of where they're at in the workup process. When will their evaluation be scheduled? Is there anything that's holding up the evaluation? And any other, issues that we might have while they're going through that evaluation process. And then before we even see them in clinic, our financial coordinator will start working with our insurance company and getting any needed approval or needed paperwork to even get that appointment financially cleared through their insurance company. So there's a lot that goes on behind the scenes before a patient's even seen in our clinic. So once an appointment is scheduled, that's actually a very busy appointment for a patient, and sometimes it could be a little overwhelming. It's generally at least a 3-hour appointment. Oftentimes they've never met any of us, so we're all kind of new faces, all given new information. So it can be, a little overwhelming for somebody who's, just learned that possibly they might need a liver transplant. But once they're seen in the clinic, generally they'll see their assigned hepatologist first. And oftentimes, that hepatologist will do an assessment, kind of determine what's going on, and they have a couple of different things that they can do at that point. Sometimes we'll see patients, and the hepatologist will tell the rest of the team members, that it's not really necessary to see them, that we're not going to work them up for transplant. And sometimes some of those reasons might be that, maybe it's a little too early for transplant. They may have liver disease, but it's compensated and their MELD score is relatively low. So they don't need to really, be worked up at that particular time. So in that case, the hepatologist will communicate with the referring physician, thank them for the referral, and then just let them know that, what the outcome was. Sometimes, it might be too late. Maybe the person is too ill for transplant. If they have, things that would prevent them from being transplanted, like advanced cancer or other things. So in that case, most of the other team members wouldn't see them because we're not going to work them up for transplant. So in addition to meeting all of those team members on their first appointment, and for those who are worked up, then the nurse practitioners that see them will order, a full workup, pretty much, head to toe testing to make sure that this is their best option. And during that time, we also make a referral to our transplant psychologist. So he will generally see people, maybe a couple of weeks after we've seen them in that initial appointment. And then they'll also see a transplant surgeon, once most of their workup is done. They'll kind of look at the overall picture of all of the testing that the patient's gone through and make a determination surgically. So generally this workup can take, several weeks or even longer before a patient is presented to the selection committee. And sometimes there's different reasons for that. Sometimes the patient might not be, as motivated as some other patients to get their appointments scheduled as quickly as they can. And sometimes, even though they have liver disease, they may still be working. So they're trying to juggle, all of these different appointments with still their work schedule, their family schedule. Some of them may be in school. So they have multiple things going on that might prevent them from, getting this workup done timely. Sometimes there might be insurance factors that might delay the workup. Some insurance companies require authorizations for every single appointment. So it can be a real struggle for the transplant staff who's trying to get these patients worked up quickly so that we can hopefully get them listed. So sometimes the insurance can be a barrier too. So during this several-week process when somebody's going through their transplant workup, this is the time that the social worker is generally working with the patients and their families, trying to remove any barriers that there are to transplant. So sometimes, during that initial evaluation, we identify, many issues that need to be, solved before we can put them on the liver transplant list. Sometimes we might do an inpatient workup. And the reason for that is if a patient is admitted to the hospital and they're determined to be pretty critically ill, and we feel that they're too ill to, be discharged and to do the workup on an outpatient basis. So that can be a little more challenging because that workup is generally, done and sometimes in a few days, depending on how sick the patient is. And if the social worker has identified, concerns that they may have with this patient's candidacy, then, they don't have the luxury of that at least several weeks that I might have on an outpatient to work with that patient and family. So they're really trying to remove any potential obstacles fairly quickly because the patient is so ill, we need to make a decision. Either we're going to list them or we're not going to be able to. So all patients, whether the workup is done outpatient or inpatient, will have a formal presentation to the selection committee. And it's this committee who will determine who's put on the list and who might not be. And the committee consists of all the transplant team members, all of our surgeons, all of our nurse practitioners, our hepatologists, social workers, our psychologist, Dr. Norman, the pharmacist, our dietitian, our financial coordinator. So everybody has their little piece that they might present during the committee meeting to determine if somebody's going to be a good candidate or not. So for social work purposes, sometimes it can go in a couple of different ways. When we're at that selection committee meeting, we can, social worker can approve a patient for listing, that there's no potential barriers that we've been able to identify, or if there were, we've been able to work through them so that they may be approved. Sometimes a patient is, denied for transplant, that there's just too many, social issues that we weren't able to resolve prior to this meeting, and we didn't feel that they would be a good candidate, so they could potentially be denied. Or another thing that may happen is if the social workers identified problems, but we feel like we can work with the patient and the family, we have another option, which is to defer a patient. And if that happens, then generally we have about 90 days. We keep them on our PAM meeting list, and we have 90 days to help that patient and that family to remove any potential barriers. And then if we're able to do that within that 90-day period, then we're able to accept them for listing. If not, then unfortunately, then they would be referred back to their referring hepatologist and not listed at that time. So some of the goals for the social work assessment is to help promote fairness and equal access to services. We want to help maximize the optimal post-transplant outcomes because it's a scarce resource. As we talked about, there's so many people waiting with, not enough donors. So it's really a scarce resource that we try to utilize the best that we can. We help to ensure that the benefits outweigh the risk by identifying any potential psychosocial factors. So during this initial assessment, the social worker will generally spend at least an hour, sometimes even longer, with the patient and their family initially, and then ongoing throughout the workup process and the listing process. But on our initial evaluation, we're kind of doing a full life story. We're looking at any potential access that might be, a potential problem. So we look at, demographic information. Where does this patient live? Are there any structural barriers where they live? Are they in a wheelchair and there are stairs, or do they have a cane or a walker and there are structural barriers that might jeopardize their safety? Who do they live with? What's their relationship status? Are they married or have a significant other, or do they have children and siblings? So we're kind of looking at their whole support system here and kind of identifying where this patient might be able to find support for pre-transplant and post-transplant. So we look at their education and their work history. Do they read and do they write? And the reason why that's important, we can certainly work with patients who have challenges in that area, but transplant can be a little challenging, and sometimes there's a lot of instructions that they need to follow for some of their testing. There's a lot of medications after the transplant that can be a little complicated. So we try to assess the best that we can, their ability to understand those instructions and be able to follow them. And there's, some unique little challenges that we have, but our pharmacists and nurse practitioners and the team are pretty good at working with patients, and sometimes we may use like a numbering system for medications, or like color code them so that they can correspond the color with the medication or the number with the medication. So there's different things that we can do with that. So we also, is this patient working when they're being worked up for transplant? How long have they been with their employer? And the reason why that's important for the social worker is because it helps us determine what kind of benefits that they might be eligible for. Are they going to be eligible for, to take time off? Do they qualify for FMLA? Are they going to qualify for state disability? Because those things become quite important because, after the transplant, they are off from work, possibly for several months. So they have to start thinking about, those financial, challenges that they might have. So if they are eligible for some of those programs, that can help them financially. We are also, checking for their health literacy. Do they have the ability to understand and process the information and to make, appropriate decisions for themselves? Oftentimes we'll have patients who, they've had liver disease for quite some time, but despite that, they still don't really have a good understanding of their medications, of their illness, of their symptoms. They don't really quite know what to do when they get sick. So we try to work with them on that. The social worker is looking at their functional level. Do they have a wheelchair, a cane, or a walker? Are they bedbound? Are they safe at home? Are they at risk for falls? So we're looking at all of those areas. We look at their psychiatric history, if they have any. Do they have any depression, anxiety, bipolar? Those are some of the common ones that we might see in clinic. If so, do they have any active symptoms? Have they ever had suicidal thoughts or suicidal actions? Have they ever been hospitalized for psychiatric purposes? Are they on medications? Are they compliant with those medications? Are they seeing, a provider for that, either, like a psychiatrist or psychologist? And if so, it's very important for the social worker to collaborate with those other providers, because transplant can be very stressful, and if somebody doesn't respond to stress well, their mental illness can possibly get worse. So we want to work with those, other providers that are seeing the patients and try to help support the patient the best that we can. During the initial assessment, too, we're also looking at, their substance use history, alcohol history, drug history, and even tobacco. So we're looking for, any potential past behaviors that might show dependence on any of the drugs or even abuse. We talk about, when did they last use alcohol? Have they ever participated in a rehab program? Do they have, any history of relapse? So we look at how, if they've used these substances, how it's impacted their life, not necessarily how much they've used, but has it caused legal problems for them, social problems, relationship problems, things like that. We're also looking at, do they have, any legal history? Obviously many of our patients may have things in their past, but do they have anything that's pending? Is there any potential we work this patient up for transplant, possibly list them, but is there any possibility that that they could be incarcerated? Because, obviously if somebody has that risk, then they would need to work those issues out before we can consider them for transplant. We also assess for any religious or spiritual beliefs that a patient might have. Is it okay for them to have blood transfusions? Do they understand that they'll be on lots of medications? And, what are their thoughts with Western medicine? So we're looking at all of those areas. One of the important areas that we're looking for is their social support. For liver transplant, we require that our patients have at least one identified appropriate caregiver who can provide 24-hour care for 3 months. And that's pretty significant for many people, obviously, especially if they're working and they'll need to take that time off, particularly if it's a spouse, because now you may have a patient who's going to be out of work for post-transplant, but also a spouse. So you're losing that double income. But we do require that they do have somebody 24/7 for about 3 months. And honestly, most of our patients don't require that much time for recovery. We have many good recovery times, and the patient is able to learn their medications, and they're able to be independent before that time. And if that happens, then we work, with the physician and the patient and their family and release their caregiver early, so that caregiver is able to go back to work or attend to other things that they need to do. But it really is pretty intensive care, particularly for the first month. That caregiver is definitely helping with managing multiple medications that change very frequently. They're helping the patient check their blood pressure, their temperature, their blood sugars. They're helping them possibly with insulin. They're driving them to UCSD 4 times a week. All of our patients post-transplant for the first month come 2 times a week for labs, and then they have 2 scheduled appointments. So even that can be very challenging for our patients who live locally, even if they just live in El Cajon or Spring Valley or something. Coming 4 times a week and they're on disability, just that added gas and things like that can be really difficult for them. So we also, will assess, what the household income is. Do they have the ability to pay these extra expenses that are going to occur related to, so many appointments? What kind of insurance do they have? And our financial coordinator is mostly involved in that. But if our patient is working and they're going to be offered transplant, oftentimes their insurance is tied to their employer. So if they're not able to get back to work timely, they may have to COBRA, which can be extremely expensive for a patient who's already out of work. So those are all things that we need to look at. And another thing that we look at, are they actively using substances or any recent substances? We do have certain requirements for patients who've had any history of dependence or abuse. So we do a full, kind of assessment and determine, does this patient need to do any kind of rehab program before we can consider them for transplant? Oftentimes they do. And oftentimes we try to give them as many options as we can, but sometimes they're a little resistant to that. But they have the option of doing 6 months of AA, and they are required to go 3 times a week. They have to get a log signed every time they go, and they're responsible for bringing that to me in clinic to get that into their medical record. As an alternative to that, we have allowed patients to participate in individual therapy with a licensed therapist. If they choose that route, then we'll be, in touch with that therapist, following up. Are they keeping their appointments? Are they following through with any recommendations that you have? Are they really participating in that therapy? So we also look at non-adherence to any past medical care or medications. Sometimes, like we discussed earlier, they can really benefit from further education on some of those things. And again, we look at financial limitations that they might have. One of the big things that we identify in clinic goes back to that needing that caregiver for that 3-month period. Sometimes we'll find that patients will come and they just have nobody that can commit to that kind of care. Or they may have somebody, but maybe this person doesn't drive. And we don't like for our patients to take any kind of public transportation, particularly post-transplant, just for the risk of infection. So if they do have an identified caregiver, they do have to come up with a plan for transportation also. Maybe they have a caregiver, but the caregiver works and they can't take time off. Sometimes they might have a caregiver, but that caregiver may have, health problems also, or maybe even mental health problems. So we're kind of working with that patient, that family, trying to assess that and to see if that might be a potential problem. Lack of transportation is a big one that we have. Sometimes people will drive, but they might drive only in their little local area, like if they live in Fallbrook or somewhere else. They don't like to drive on the freeway, and obviously they would have to drive on the freeway to get here for their appointments. So even though they have a caregiver and that caregiver drives, we still have to continue to explore any additional supports for that. So oftentimes another common risk factor is mental illness that may impair their ability to follow through with medical appointments and medications. So we look at have they stopped medications in the past. Sometimes people will stop medications because they feel like they don't need them any longer, or they stop them because there's too many side effects. Sometimes patients may not have a documented mental illness, but they may just have poor coping skills where they don't really respond to stress very well. And transplant can be very stressful, so it can kind of create a problem for them with transplant. Another common risk factor that we may see is ambivalence regarding transplant. Medically they may need a transplant, but they're just kind of on the fence. Do they really want to make this decision to have this big surgery and to be committed to taking these medications for the rest of their lives? Sometimes patients they may not want a transplant, but their family wants them to have a transplant. So that's another thing that we run into that we have to work through. And sometimes patients may have personality challenges that make it difficult to work with the team members. And because we do work so closely together with patients and families, that it really is, a team effort. And again, any pending legal problems we've come across in clinic before where we've, unfortunately had to not accept people for transplant. So what can a social worker do when they've identified some of these risk factors? The main thing is that we work with the patients and the caregivers, and we try to help them explore their entire support network. Support can come from many different places. It can be friends, it can be family, it can be church members, even affiliated churches, where one time we've had a family who was involved in their church, and that church called an affiliated church here, and that was extra support for them. It can even come from AA teams, AA members, so anywhere where that patient might have support. We try to educate the patients and the caregivers about any potential resources that they may be available for, such as food stamps, in-home support services, paid family leave, FMLA, and any kind of disability programs, therapy, psychotherapy, home-delivered meals, and also fundraising is a big one. Some people may not be familiar with fundraising, but there are actually agencies that work just with transplant patients on doing fundraisers, and this can really help with some of those out-of-pocket expenses, with the travel and with the gas and just with their insurance if they have high deductibles and co-pays. And the nice thing about that is if patients do participate in fundraising and they're on state or federal benefits, it doesn't impact those benefits because the fundraising agency actually keeps it into an account for them. It does not go into the patient's account. And then when they have an unpaid bill related to their transplant, they can submit that to the fundraising agency who will pay that bill. But when you try to talk to patients about fundraising, a lot of them are a little squeamish and kind of, it's a little scary for them. So we oftentimes will make referrals to many community resources to try and help with this. We collaborate with outside providers, especially mental health providers. We provide education and support for our patients and our family. Our nurse practitioners have 2 times a month where they have a new patient orientation, and this is a required class for our patients where they have to come and they're in a class with other pre-transplant patients where they're just doing a lot of education on the transplant process, diet, medications, anything that a patient might need to know. We also have a monthly support group for our pre-patients, our post-transplant patients and caregivers, pretty much anybody who wants to come. So that's once a month that we offer, and patients can find support from other patients, particularly our post-transplant patients are helpful for our pre-transplants. We also have a mentor program where we have post-transplant patients who volunteer their time to meet with pre-transplant patients who just might be, kind of struggling with needing a transplant, kind of fear of, what might be expected. So we have volunteers. One in particular comes to clinic and he will meet with people one-on-one. He'll call people. So he's really great. And they go directly through volunteer services for training, and then they're available to us to use as that resource for our patients. Okay, so obviously with transplant, there's always areas that are going to be a little controversial. So some of the things that may come up in transplant is when somebody might need a transplant due to a suicide attempt, or if a patient is recently abusing or perceived to be abusing drugs or alcohol. Especially if a patient has alcohol hepatitis and needs a transplant. This can be a pretty sticky area for many transplant centers. And then we have to think about also with marijuana in California, it's legal with a prescription. So transplant centers are kind of struggling with, well, it's a prescription, do we allow that or don't we allow that? There's a hospital in the LA area who recently just developed a policy on alcoholic hepatitis where they do transplant patients who have acute hepatitis due to alcohol. So you can imagine that that's very controversial. It's a strict policy where the patient did not have any known liver disease. They've never had any problems related to drinking. Like they've never had a DUI, they've never had family problems, they've never missed work, no problems like with, past adherence with medical care. So, and I think as of last month, they'd actually done 5 patients. That's kind of a new thing for many transplant centers because I think for many of them, they would probably say no. If they need a retransplant due to non-adherence, if they weren't taking their medications and they weren't following up with their medical care and now their liver's failing again. So that can be a little controversial also. If somebody has cognitive impairments that won't be corrected by transplant, sometimes that comes up too. So for the social worker, we take all of these little pieces and we try to put them together. And the minimal thing that I think for approving somebody for transplant, for me, would be that the patient wants a transplant. They want it for themselves and not necessarily for their family member, but they want to live. They want to be able to go on and do things, maybe return to work, do some hobbies that they used to do that maybe they haven't been able to do for a while. They have to have a working relationship with the transplant team, that they're working as a team member, not directing their care, refusing to come to appointments, refusing to take medications. They have stable housing. Where are they going to recover post-transplant? They have to have somewhere where they live that's safe, where the caregiver can take care of them. They're not actively using any substances, and if they did need to attend a treatment program based on the assessment, they've been following any recommendations that we've made for them. That they have the means to get to their clinic appointments and they have the means to get to their labs. They have to have, the caregiver that can commit to that 24-hour care over that 3-month period. A caregiver who can work with the transplant team, who can understand the medications, who can drive them to appointments, who may even be able to do a little bit of wound care with teaching. We teach, our patients and our families, everything that they need to know to take care of our patients. They have to have the ability to stay in San Diego at least 6 weeks post-transplant. And that's for our patients who might come from out of the area. We have a lot of patients who come from Imperial County, even other states and other countries sometimes that we can consider for transplant. And they have to have the ability to stay here at least 6 weeks so that they can get the adequate follow-up care immediately after their transplant. And unless they have really good private insurance, that 6 weeks is, their own expense. Especially for our Medi-Cal patients or our Medicare patients, that insurance doesn't pay anything. And we have, you probably are familiar with Bannister House, which is really great. It's definitely a reduced rate compared to a hotel or an apartment rental, but they oftentimes have a waiting list. And even at the Bannister House rate, when you're thinking about staying here, for 6 weeks on somebody who has an income that's disability, that can still be extremely challenging for them. they have to be reasonably adhering to their medical treatment. So what that means is oftentimes people want to do the right thing, but they just don't have the education. So our nurses and our doctors and, dietitian, where all of us are, teaching these patients, supporting them, so they have to reasonably be adhering to them. And they don't have a mental illness that can impact their ability to care for themselves. So somebody can certainly have a mental illness, but they may be stable on medications and have a psychiatrist or psychologist that they're working with. So what can the social worker do, while the patients are waiting for transplant to be helpful? So some of the things that we work with are to help patients understand that some depression and anxiety, are normal. This is a big process. It's a long, frustrating process for the patients. Some of them wait for a very long time, and they're very ill, and it can be very challenging. So we work with them to, help them understand that that's normal sometimes. We want to acknowledge their feelings, especially when they're having, really bad days and they're not feeling good and they can't do things that they used to do. We want to encourage them to optimize their nutritional status, which is a big one for liver transplant patients. We encourage them to do, to stay as active as they possibly can, while they're so ill, to at least do one normal thing every day. We encourage our patients to stay connected to their support system. Oftentimes they just want to stay at home and stay in their room and watch TV, and they're a little isolated, particularly if they have a caregiver who's working and they're home during the day by themselves. To help them look for support in unexpected places. There's social networking, blogs, there's online support groups. So there's all kinds of things that they can utilize. So I think over the 5 years that I've been working with liver transplant patients, some of the things that I've learned that's important is to learn how to be patient. I have to understand that not all patients are in the same ready for change cycle than what I want them to be. Just because I want them to do something doesn't mean that they're ready, and especially particularly like with treatment programs, like if a patient said they've stopped drinking and they don't feel like they need a rehab program, but I might think so, or a transplant psychologist might think so. So we're requiring them to do things that they may not necessarily think are needed, but it will be needed if they want to be listed for transplant. So I have to recognize that not everybody is on the same page that I am, and work with them to set appropriate goals which they can live with but still meet the minimal listing criteria. That to help patients focus on what they can control and what they can't control. And to understand that our patients, particularly our very sick ones, are preparing for two journeys. They're preparing for hopefully life, but also for death, because people do die waiting for transplant. And most importantly, to listen to what the patient wants, what they think, and what they feel. So these are just some statistics that I've collected just to give you maybe a better understanding. That as of last week, we presented 135 patients to our selection committee during this year. Out of those 135, 25 were declined for social reasons. It's not always just social reasons. There could have been other reasons why they were declined, but 25 of them did have social reasons that or barriers that we didn't feel that would be appropriate for transplant. And eight patients were deferred for social reasons. And out of those deferrals, 2 were eventually listed and transplanted. One's currently on the waiting list. 1 was lost to follow-up. And 5 continue to be deferred, and they have those 90 days to work with the social worker to help remove any potential barriers. That's all. Any questions?